Hello, my name is Dr. David Liu, and this is my submission to the ACP Northern Illinois Abstract Competition titled A Full Body Group A Streptococcus Experience. The patient is a 31-year-old healthy female who presents to the hospital with progressive dyspnea and arthralgia in the right knee, bilateral hands, and bilateral ankles for 2 weeks. The patient denies any associated fevers, chills, headaches, or any neurological symptoms. Social history was also unremarkable. On presentation, blood pressure was 97/64, heart rate was 146, with the rest of the vitals remaining stable. Physical exam showed swelling, tenderness, and warmth to touch in the left posterior shoulder, third metacarpal of the right hand, right anterior knee, right thigh, and bilateral ankles. There was no noted joint erythema, fluctuance, or recent trauma. Initial laboratory testing showed neutrophil predominant white blood count of 21,700, hemoglobin level of 12.0, platelet count of 69,000, ESR of 48, CRP of 300, LDH of 263, as well as elevated creatinine, bilirubin, and liver function tests. Blood cultures were immediately obtained and empiric antibiotic coverage with ceftriaxone, azithromycin, and vancomycin was initiated. Subsequent CT chest of the patient showed consolidation in the bilateral lower lobes. Multiple blood cultures grew Streptococcus pyogenes susceptible to penicillin. A transesophageal echocardiogram was done to rule out endocarditis and was unremarkable. Aspiration of the right knee showed 219,000 nucleated cells with 92% neutrophils. Patient was then taken to the operating room and underwent irrigation and drainage with carpal tunnel release of the right hand, aspiration of the right wrist, open arthrotomy of the right knee, multiple fasciotomies of the right leg and thigh, and aspiration of the bilateral ankles. Surgical cultures of the knee, ankle, and finger grew Streptococcus pyogenes. Antibiotics were adjusted to IV penicillin G and clindamycin. Despite continuous antibiotics, there were persistent loculated pleural effusions. Bilateral thoracentesis showed exudative effusions. Follow-up CTs showed a right-sided empyema, and the patient underwent a right thoracotomy and complete decortication. Patient condition improved and was later discharged on IV penicillin with frequent follow-up. Her primary source of Group A strep remained unclear. This case describes a Group A Streptococcus causing a debilitating and strenuous hospital stay for a previously healthy patient. Group A strep is a gram-positive beta-hemolytic coccus in chains that can cause several different infections, including bacteremia. Identifying the source can be a challenge in up to 40% of cases. In the absence of clinical signs, the diagnosis can often be delayed, leading to high mortality. Based on literature review, there have been no reported cases of a Group A strep causing toxic shock syndrome, empyema, and multi-joint septic arthritis in an adult with no comorbidities. Although primarily seen in children, physicians should retain a high index of suspicion for Group A strep in patients with septic joints and hemodynamic instability. Group A strep can also cause potentially fatal infection if not promptly recognized and treated. Our case emphasizes the importance of swift diagnosis, early antibiotics, and timely intervention. Thank you for listening to my presentation.